Order. I call the meeting to order. This is the Standing Committee on Health. I'm John A. McDonald. I'm the chair and the member for Hants East. Today we will hear from Nova Scotia Health, the Office of Addiction and Mental Health, the Alley Centre of Cape Breton, and Direction 180 regarding withdrawal management services. Just a reminder to put all your phones on silent. I will now ask the committee members to introduce themselves by their name and their constituency, starting with MLA Barkhouse.
Good afternoon. My name is Danielle Barkhouse. I am the MLA for Chester St. Margaret's.
Good afternoon, everyone. Chris Palmer, MLA for Kings West.
Thank you for joining us. I'm the MLA for Glace-Bain Dominion, John White.
Welcome back. Nolan Young, MLA for Shelburne.
Hello, I'm Susan LeBlanc, the MLA for Dartmouth North.
Hi, I'm Lisa LaChance, the MLA for Halifax, Sable Island.
Good afternoon to all, and Rafa Di Costanzo, MLA for Clayton Park West.
Good afternoon, Fred Tilley, MLA Northside Westmount.
For the purpose of Hansard, I recognize the presence of Ledge Council Gordon Hebb and Legislative Committee Clerk Judy Kavanaugh. Okay, so I'd like to welcome all the witnesses, and at first I'm just going to get you to introduce your name and your position, and then we'll get to opening statements. And I'll start with Dr. Martell, please.
Dave Martell. I'm the physician lead for addiction medicine for the Mental Health and Addiction Program of Nova Scotia Health.
Good afternoon. Dana Pulsifer, Senior Director for Mental Health and Addictions Program for NSH.
Hello, everyone. Sam Hickcox. I'm the physician consultant for the Office of Addictions and Mental Health.
Good afternoon. I'm Kathleen Trott, the Deputy Minister of the Office of Addictions and Mental Health.
Hi, everyone. My name is Paula Martin, and I am the Program Manager with Direction 180 and Refix Overdose Prevention Site.
Hi, everyone. I'm Jill Gardiner. I'm here from Cape Breton, the Ally Centre. I'm the manager of the Managed Alcohol Program.
And I believe we have Janah Fair, Director, Northern Zone, in the back. And if called upon to answer questions, she'll take one of either Dr. Martell or Ms. Pulsifer's spot. I just want to remind all the witnesses for opening statements to keep them around 3 minutes. We have 4 of them. And I believe the Deputy Minister is going to start. Am I correct?
Correct, yes.
Mrs. Trott.
Yep, I'll start, and then I'll ask Dr. Martell to speak, and then we'll have our community members speak, if that works.
Okay.
Great. So good afternoon, and thank you for the opportunity to join you here today to discuss withdrawal management. Substance misuse and overdose prevention have always been complex issues, and it's gotten increasingly more complex over the last 5 years. We've seen an increase in overdoses and deaths and an increasingly toxic drug supply, and we are responding. We work with our health system partners and community-based organizations to address substance use and overdose in our communities and to support Nova Scotians experiencing addictions. We've been making investments to strengthen addictions medicine and increase access to supports and programs. We're making progress on the implementation of the recovery support centers opening across the province. These centers offer one-on-one support and group treatment for people struggling with substance use or gambling. The team at these centers can provide harm reduction support, including naloxone kits and training, as well as more traditional services like inpatient withdrawal management and opioid use disorder treatment. We remove barriers by creating a walk-in service as part of this new model, so the service is there when people are ready to take their first step. There are now 7 locations across the province, including the one in North Sydney, which just opened last month, with more to come this year. And we're investing in harm reduction approaches to help minimize the impacts of drug use. There are overdose prevention sites in Halifax and Sydney, and the take-home naloxone program has provided more than 43,000 life-saving kits through community-based organizations like Direction 180 and Alley Centre and pharmacies across the province. And we provide funding to community-based organizations offering needle exchange and disposal, peer support, opioid replacement therapy, and more. Additionally, opioid use disorder treatment services are available in every health zone with 23 sites across the province, and there's no wait list for this treatment. In September 23, we launched the province's first inpatient addiction medicine consult service at the Halifax Infirmary site to provide advice for physicians providing care to inpatient units and the emergency department. And when it comes to addictions, we need to meet people where they are. That means we need a range of services and supports, everything from harm reduction and overdose prevention on one end to treatment options and recovery support on the other. We have a lot happening in this space and look forward to talking more about this today. Thank you.
And did Dr. Martell have opening statements? Dr. Martell?
Yes, Mr. Chair, thank you. Thank you so much for inviting us to this committee meeting. As the chair had mentioned, I'm Dave Martell. I'm the physician lead for addiction medicine for the mental health and addiction program. We didn't properly introduce Janah Fair, who is the zone director for the northern zone, but she's also my partner in this addiction planning work, my co-lead, and Dana Pulsifer, senior director for the mental health and addiction program. I'd like to also acknowledge our community partners. It's very important to have them at this table. Representing the Alley Center and Direction 180, we have key partnerships that allow us to be very effective by having them present and having them be part of our planning in the programs that we control. I also want to take a minute to thank this committee for prioritizing this topic. Addiction doesn't get a lot of conversation at all times in healthcare or in society, and I think it's important that we have these discussions openly. I also want to congratulate the members of the legislature who have stood up and given their own personal narratives. It's always very meaningful when that happens. It helps humanize the face of addiction. It helps us to fight stigma, so thank you. I want to start my comments by illustrating a little bit why this conversation is important. You heard Deputy Minister Trott talk about the deepening of the issues that are coming up with toxicity in the drug supply and people dying from unnecessary overdoses. That's only one part of it. Addiction issues and substance use account for perhaps a large majority of disability that happens in society. And it's probably responsible for most premature death in our culture. People live 10 or 20 years less than what is expected because of substance use and addiction. We lost 73 people to drug toxicity last year, more than we usually do. We are expecting a trend where that increases as well. And these are parents, children, siblings, co-workers. They're human beings, and we should acknowledge their loss. Addiction represents a complex set of problems for which there's no one solution, there's no one recipe. We have to individualize treatment. The complexity is normally what scares healthcare providers away from having a comfort level with providing care for people in this setting. So we really have to cooperate to come up with plans and system-level planning to make for effective treatment for this population of people. We work closely with the Office of Addictions and Mental Health, the IWK, but also with collaborators in other parts of Nova Scotia Health, partners nationally in other provinces and internationally. I serve some leadership roles across the country to that end. What guides us? We're guided by the Action for Health plan. We want to deliver high quality, low barrier access to treatment. And we're tasked now to come up with a realistic plan to implement universal mental health. We're also guided by a framework that was developed now 7 years ago, the Opioid Use and Overdose Framework that came out as part of the public health emergency to do with opioid overdoses, the same thing that we're talking somewhat about today. A lot of that framework still holds true. We need to be driven by data. There's a focus on prevention, there's a focus on treatment, there's a focus on harm reduction, there's a focus on enforcement. Coming at this problem from all different areas seems to be the most comprehensive way we can address it. But things have changed since we came up with that framework. Here, 7 years later, we're dealing with poisoning of the illicit drug supply. And I think it is time for us to prepare for a worsening, perhaps, of this problem and to do another set of planning. I know there are discussions in the works about that. I'd like to talk briefly about recovery support centers. These are hubs that we have developed where people can start on their pathway to addressing their addictive behavior and making change, places where we try to rid people of the shame associated with their disease, where there is no judgment, where we show respect, where people can have individualized care plans made. Again, there is no recipe to try to address an addiction issue. There is no cure for an addiction. We have group learning sessions that take place in these settings. We sit with people and make individualized plans for their care. We follow up with them. We form relationships. The engagement seems to be a key part of what makes this care effective. We've also, in September of last year, developed a consult service at the Halifax Infirmary designed to try to help decision makers in the hospital, caregivers caring for people with very complex problems, to ensure that they stay in hospital and receive the care that they need. Too often that doesn't take place when people feel shamed or feel judged, and not getting the care that they need, sometimes with life-threatening conditions, can have major consequences. Our team has a nurse, a social worker. We're hiring a peer worker. It's meant to be multidisciplinary and holistic. We also have a telephone advice service that is part of this program, where any nurse practitioner, physician, or pharmacist in the province can call asking for advice or guidance on complex problems.
Dr. Martell, I'm just wondering if you're almost done, because you're at 6 minutes, and so, just a sec, Dr. Martell.
In closing, thank you so much for providing this space for us to have this conversation, for us to talk about our vision. We appreciate it.
Thank you. Ms. Martin. Sorry, Mrs. Martin.
Thank you, Mr. Chair. I'm very happy to be here today on behalf of Direction 180, a program of the Mi'kmaq Native Friendship Center that directly supports people impacted by addiction in all of our communities. As I mentioned earlier, my name is Paula Martin, and I am the program manager for Direction 180 and the Refix Overdose Prevention site. Direction 180 is a community-based opiate treatment program located in North End, Halifax. We have been in operation since 2001, supporting people with substance use disorders to reach their full potential through health and social programming. We are currently treating 465 patients with opioid use disorder. Direction 180 also operates Atlantic Canada's first overdose prevention site. An overdose prevention site is a safe space for people to use drugs in our community. This safe space reduces the frequency of public drug use and the inappropriate disposal of drug use equipment, public intoxication, incarceration, the transmission of bloodborne pathogens, unnecessary fatal drug poisonings, and most importantly, the opportunity to connect people who use drugs with other health and social services. Since January 2022, the Refix Overdose Prevention site has supported a total of 399 Nova Scotians to use in a safe space, a total of 19,540 times. Refix staff have successfully responded to 7 opioid poisonings, preventing 7 unnecessary opioid deaths in our community. Direction 180 understands the importance of employing people with lived and living experience with drug use. Employing people with lived and living experience helps to ensure organizational policies, procedures, and services meet the needs of the population served. This reduces barriers and can increase service retention among people who use drugs in our community. Thank you again for having me here today to share more about what our organization does to support Nova Scotians to reach their full potential.
Thank you. And Ms. Gardiner.
Hi, everyone. I'm Jill Gardiner. I am the Harm Reduction Manager at the Ally Centre in Cape Breton. The Ally Centre of Cape Breton aims to be a supportive and non-judgmental environment. We serve populations such as folks who use substances, those experiencing homelessness, sex workers, and individuals experiencing active mental health issues. Our programs are built on a person-centered, trauma and violence-informed approach with direct access to wraparound supports. With harm reduction as a key element, we embrace those with lived and living experience, both as peer mentors and employed staff. At the Ally Centre site, located in downtown Sydney, we provide a long list of programs that address the physical, mental, and social needs of the participants we serve. Some of these include SANE, Sharp Advice Needle Exchange, drop-in services, health clinic, overdose prevention site, naloxone program, food bank, housing support staff, social worker, and peer navigators. So I'm here today to talk about MAP. The Ally Centre MAP is the second managed alcohol program in Nova Scotia. The program demonstrates best practices through a harm reduction philosophy which targets individuals who are vulnerable to alcohol use, homelessness, or at risk of homelessness, and are ready to engage in reducing the harms associated with their alcohol consumption. MAP is a palliative program in which the focus is on preventing alcohol-related harms, including those related to survival drinking, non-beverage alcohol use, alcohol withdrawal, maintaining or reducing use and harm reduction, wellness, peer mentor support, self-management, and safer drinking education. The Ally Centre MAP team provides wraparound support to MAP participants. This includes the clinical team, a MAP nurse and nurse practitioner, and a harm reduction outreach team providing daily support. Individualized care is provided by the MAP team as recommended. MAP community partners are currently providing supportive housing. A referral form is provided to the community partner through our established partnership. This is followed up with various interviews with the individual and their supports to ensure that MAP is a fit for all. The Ally Centre MAP accommodates a maximum of 20 individuals in a supportive housing environment. Supportive housing in Cape Breton. Due to the lack of harm reduction-based supportive housing models in Cape Breton, we are really struggling to implement MAP. We have had some small successes with the scattered site model, individuals who live in their own home or apartment. However, MAP is best delivered in a supportive environment with several touch points a day. In Cape Breton, we have 0 harm reduction supportive housing models. It hasn't happened yet. We at the Ally Centre have been working very closely with New Dawn to provide these severely needed models in Cape Breton. We have been met with community resistance, which has led to political movement halting the implementation of the pallet homes. We were hopeful that the pallet homes would be actively operating at this point and providing the much-needed supportive housing option that our many community members living rough need. MAP would have likely accounted for half of the pallet home occupancies, with participants who are at a palliative stage in their journey. Supportive housing models, specifically in harm reduction and palliative care, are the missing piece that we are faced with in trying to deliver MAP in Cape Breton. Harm reduction saves lives, yes, but it also offers an opportunity for folks who have been struggling their entire life to be sober to finish their days in a supportive environment, recognizing that sobriety is not for everyone. We feel at this time that it is very important to highlight the lack of movement on the systemic changes needed in Cape Breton. With the delay of the pallet housing due to community and political protests, dozens of individuals will be denied programming, and for some, a 4-month delay will mean they will never settle into adequate supported housing in their lifetime. Thank you.
Thank you. So as normal process here, each caucus will get 20 minutes. At the end of the 20 minutes, I'll divide by 3 to see what the next round is. If at the end of the 20 minutes you hear order, it's not being rude, it's just to get it going along. So, and the first will be for the NDP, or sorry, Liberal, and I'm looking right at you. So the Liberal Party, and it'll be MLA Di Costanzo.
Thank you. First, I want to start by just thanking actually Direction 180 and the Alley Center for the amazing work they do. It really does make a huge difference in your communities, and I hear a lot about it. So just want to acknowledge and very happy that you are here as well. My first question, however, is for the NSH, and probably to the deputy. The government promised recovery support centers throughout the province, and they are so needed because the long times are still very long. We know that it is in some clinics are over 100 days. I saw one of them was 122 days, and for the non-urgent visits, and over a week, and one of them I believe was over 9 days for the urgent visits. The Halifax site has been delayed in opening. Can you please give us an update as to when the Halifax Centre will be opened and why there is such a delay?
Deputy Minister Trott. Deputy.
Oh, there it goes.
Oh, I guess this.
Well, I'm going to pass it over to Dana Pulsifer, who leads that initiative.
And then she just dumped it.
Okay, just a sec. They're double. Ms. Pauls?
Sure.
You can start and then punt it to me if you want to, okay?
Yeah. Thank
Okay.
you. I was just trying to hear the entire question.
Sure.
Sorry, the
The
sound
noise.
is a bit long.
Yeah, construction's not being nice.
Do you want me to repeat it?
Do you need it repeated?
I think I pieced it together. I think your question is about the recovery support centers and how we're in the one in Halifax.
Or MLA Di Costanzo.
Sorry about that. Yes, just that we are still having very long wait times all across the province, but some of them are, for the numbers that I wanted to quote is for the non-urgent is over 100 days. Some of them were 120 that I looked at. And for the urgent is still over 1 week. Some of them are 9 days. And specifically, we were supposed to have one in Halifax opened by now, but there's a delay. So why is the delay and when is the expected time?
Ms. Pulsifer.
Sorry.
We do it, don't worry.
Thank you. So I'll answer. I think there's a couple of different questions in there, and then I will likely pass it over to Dr. Hickcox for a little more detail. But I think some of the wait times that you're quoting is related to the outpatient community mental health wait times when you talk about over 100 days and the 7 days. So our recovery support centers, really they're walk-in related, or they can call the intake line to be given an appointment, or they can call the actual recovery support center in their specific location and arrange for an appointment and an assessment. So those wait times are really applying to our outpatient or our community-based mental health and addiction clinics. For your second question, though, about the delay, some of the recovery support centers that are to be launched and have had a bit of a delay typically is related to the construction and renovation timelines. They keep being moved, unfortunately, and some of it is related to the hiring and the recruitment of either addiction physician positions or some of our allied healthcare positions. But I'll just ask if Dr. Hickcox could relate to the specific question.
Dr. Hickcox.
Hi, Rafa. I think the reason they punted this to me is that I'm the addiction medicine physician who's going to be working at the Halifax Recovery Support Center when it gets set up. So they did recruit somebody. Yeah, so I've sort of been intimately involved with sort of what's happening in terms of the delays and so on. And I would echo what Dana is saying, that the majority of the delays are really due to supply chain issues regarding the renovation of the existing space that's there, getting labor, skilled labor to come in and, kind of put in the appropriate physical kind of requirements of the space, like the electrical system, et cetera, right? So it has, in the case of the Halifax Recovery Support Center, it has less to do with recruiting healthcare providers. They're really, really close to full complement. Basically, we're going to be having a conversation with a nurse practitioner on Friday with the aim to bring them on board, and otherwise they're pretty much at full complement, kind of waiting for the space to be ready to be used, which is coming very soon.
MLA Di Costanzo.
Can you clarify very soon?
Dr. Hickcox. You want to defer that to someone else?
Yeah, no, it's okay.
Okay.
Yeah, no, I know. So, as of today, I've been told to show up on the 13th of May and start admitting patients that week. Okay, so yeah, so that's I think it's very credible that we'll be getting going in mid-May. For sure. It takes a while to roll these things, to roll out all the services, of course, and get things rolling. But yeah, so stay tuned for that. I think, just a couple of things like the space that I just get excited about the space itself because we're actually right next door to one of our universal mental health care pilot sites, the psychology clinic that's being run by Dalhousie Psychology Training Program. And their mandate is to really address the needs of folks who are really struggling with being insecurely housed or are unhoused or living at the margins. And so we see an opportunity to really provide collaborative, co-occurring care for people who normally can't afford a combination of psychological care and actual addiction medicine care. So just wanted to point that out. But and a final piece, like it's really important to recognize that our model of addiction care that we've conceptualized of, the attempt is to take into account what's happening to people who are in the throes of addiction, right?
Yep.
So when people are struggling with substance use, that really eclipses everything else in their life. It's very difficult for people to maintain an appointment for 2, 3, 4 weeks, 6 weeks down the road, right? So really immediate walk-in access is what we're aspiring to. We're not there with all the RSCs yet, but that's sort of the core of the model.
MLA Di Costanzo.
Sorry. If you don't mind, if you can keep it to the timeline. So I'm trying to figure out when will Halifax, and I'm very grateful. I've got an estimated and a very good time. My second one was the hub for Southwest Nova will be opened. When will that be opened? And and if you can give me the other ones that have been promised, an approximate time that you're expecting them to be open. I would really appreciate that.
I'll wait for the Deputy Minister to tell me who I'm going to. Dr. Martell.
The question, MLA Di Costanzo, was about Southwest Nova. Recovery support centers in the southwestern part of the province. You're referring specifically to Yarmouth. There is also a recovery support center in Middleton. The challenges that we've had in that part of the province to effectively stand up a service like this have to do, again, with health human resource planning. We had great success through last year recruiting a physician to work in that site, and then a family issue had come up and the person had to back out. And we're still continuing our recruitment effort. We've also, on top of that, developed a situation where we've had a flood in the Abbey J. Lane building, and some of the staff who are working in the Yarmouth site have been seconded to help out with patients who had been in the Abbey Lane. I know that's temporary, but staffing going into other care settings can fragment our ability to build our NRSC. And in Yarmouth, that's what's taking place right now. We hope to have it back up as soon as we can, but there isn't a specific timeline.
MLA Di Costanzo.
So for Southwest Nova, it is staffing rather than location. The location is ready. It's just you're having a hard time to staff
Dr.
it.
Martell.
Yes, that's correct.
MLA Di Costanzo.
Sorry, yes, you're right. And for Middleton was the same for both of them right now?
Dr. Martell.
The situation with the Recovery Support Center in Middleton is a little different in that the space is not within a specific hospital setting, and staffing issues are more in flux, but we have service up and running in the Recovery Support Center in Middleton presently. It's an active Recovery Support Center.
MLA Di Costanzo.
Don't want to spend all the time on this, but what other centers that are you having a hard time with? How many more centers are you opening, and which ones are you expecting to have some success as the Halifax one?
Dr. Martell?
The ultimate vision was to have 11, now we're thinking of 12, geographically distributed throughout the province. We have 7 presently open. We have 3 more about to open within the next few months, and trying to put plans together to have all 12 open just as soon as we're able to have the recruitment piece, the staffing piece in place. So those are the numbers.
MLA D. Costanzo.
Perfect. That's exactly what I was looking for. Thank you so much. My second question is also, I heard from physicians actually who work in addiction and withdrawal management on how difficult it is to have successful continuum of care for patients living with addiction because the management of opioid is, and they've actually sent an email, I believe, to the deputy to have an electronic medical record to help them with the continuum of care for patients. And so I'm just wondering, when will withdrawal management and opioid clinics be able to transition to electronic medical records?
You? Dr. Martell?
Thank you, MLA D. Costanzo, for asking that question. And it's a question I myself have had about what is our vision for documentation and communication within addiction settings in the province. We have undertaken a project, as you know, provincially, to try to bring all of these systems into one system called one person, one record, or one patient, one record. And we're hoping to blend the conversations about the development of that program into, well, what are the needs that we have within our mental health and addictions programs to communicate and to document that care. So we're hoping that the development takes place at the same time.
MLA D. Costanzo.
So the OPOR is a 10-year program or a 10-year long time. So what are they doing right now when they're struggling? Honestly, is what are they going to use? Meanwhile, they're using paper, very archaic, and it's just very discontinued, especially now with not having a family doctor, and you're going to a virtual care, you're going to pharmacists. The information is all over the place, and it's 10 times harder when you have an addiction that needs continuous follow-up for them. So these patients are truly struggling, and the doctors are struggling with this. So opioid is OPOR, not opioid, is a 10-year thing, and also does not include family doctors. With the investment that we just announced, or the new government announced, that does not include family doctor. So it could be another 10 years after that. So what are they supposed to do in the meantime?
Dr. Martell.
MLA D. Costanzo, you're preaching to the choir. I'm one of these physicians, and I struggle myself with the archaic nature of the way we keep track of notes. I think this might be an opportunity for one of our community partners to speak about their success with that physician piece, and I'd maybe call on Paula Martin to talk about the use of electronic health records in the setting where she works.
Mrs. Martin.
Sure. Yes, so at Direction 180, we do currently use an electronic medical records system, and it has been a very useful tool, not only for our patients, but also for physician transcribing. Physicians' handwriting can oftentimes be difficult to decipher, so it has really enhanced the care we're able to provide through our clinic, as well as collaborating with other health and social services through the use of an electronic medical record system. We were able to do this more easily because we're not positioned in a hospital, so we are not a hospital-based program. So I would expect that some of the challenges in the Nova Scotia Health Authority opiate recovery programs, if they're positioned or based within a hospital setting, that they would have to follow the similar record-keeping mechanisms where they're positioned. Yeah.
MLA D. Costanzo.
Thank you, and thank both of them for the answer. And how much time do I have left?
Just under 6 minutes.
Okay, and I'm going to pass it to my colleague, Mr.
MLA Tilley.
Thank you, Mr. Chair, and thank you all for being here today. The first question I have is regarding an organization in Yarmouth. So the leader of the party and MLA for Yarmouth wrote to the minister earlier this month about a long-time organization in Yarmouth called Langhouse Yarmouth, a youth centre that provides peer support and programs for those living with mental health challenges, and they were suddenly informed that they're being shut down. So no information was conferred to the members of the organization behind this reason. So in a time when we need more mental health and addictions for supports with youth, why would the department shut down Lang House in Yarmouth?
Deputy Minister Trott.
Hi, thank you. The department didn't shut down Lang House in Yarmouth. It was a decision made by the Lang House board to make that decision, and we were notified after that had taken place, but we are working with the organization now to determine what led to that decision and how we can work together to support services for youth in Yarmouth. I understand the Halifax Lang House is providing virtual support currently, but we're working with the organization to determine what the path forward is there.
MLA Tilley. Looks fine.
Thank you, Mr. Chair. Thank you for that. Another question I have is around inpatient beds for withdrawal programs across the province. So how many beds do we currently have, and are they full, and are we fully staffed?
I'm seeing them all look at Dr. Martell. Am I correct? Dr. Martell.
Again, keeping track of exact numbers is challenging because they're ever in flux. And just this past week, the same way in Yarmouth, we have had to second some patients to the inpatient withdrawal management unit at Simpson Landing. We've only ever been able to have programs partially up and running through the pandemic, initially due to pandemic restrictions, but then due to health human resource staffing issues. We're really still trying to emerge from that. Part of this conversation is also a conversation about the model of care, that the questions like, should we be siloing care for people who have a medical complexity of their addiction such that they need to be hospitalized to help them come away from the substance? And I think it's an opportunity that we have not just to reflect on beds, but to reflect on the care itself and whether or not people who have that need, who require a hospital, should be allowed to get treatment in an actual hospital and not a withdrawal management unit. I'm not speaking on behalf of the program in those words. The other thing I'll point out is that we have a lot of conversations often about beds, and that is how we kind of keep track of the numbers of what we need and what our capacity is. And I'd suggest that there is a hint there that the best way to treat somebody who has an addiction involves them lying down. We need to look at capacity with other measures and not just by how many beds there are.
MLA Tilley with just over 2 minutes.
Thank you, Mr. Chair. So regardless of the number of beds across the province, I guess it would be a better way to phrase this, the level of service from Cape Breton to Yarmouth, would it be consistent levels of service throughout all of the regions, or is there one or two regions that have exemplary service, or would there be one or two regions that require more help and staffing?
Dr. Martell.
That one is quite easy for me to answer, MLA Tilley. I live in one of the regions that doesn't have a designated inpatient withdrawal management unit. We have a cooperation with another zone to try to provide that care when it is required, although because of the distance and the logistics, it often doesn't easily take place. So we really need to reflect on the model, but that inequity has to do with where these inpatient units historically were and their legacy.
MLA Tilley.
Thank you, Mr. Chair. So I guess with probably 30 seconds left.
No, 55.
55 seconds left. Very good. So can you give a recommendation then of how we could improve this type of service for patients across Nova Scotia?
Dr. Martell.
55 seconds or less.
My recommendation, I alluded to looking at the model, and the way I would reflect that back to you is that we have had very effective models of care where people really need sheltered care treatment in other parts of the country, and drawing from that experience and taking the best of the examples in terms of their outcomes, their health outcomes for patients, I think is the path forward. There's some index ones like designated hospital wards in places like St. Paul's in Vancouver, and the ARCH program that has a cooperative effort with emergency departments in their area where they have swing spaces where they do more complex care. Drawing from those models, I think, is the solution.
Order. That's perfect. The 20 minutes are up. The NDP, MLA LeBlanc.
Thanks very much, Mr. Chair, and thank you all for being here. I just have a couple of quick questions before I pass it on to my learned colleague, but most of my questions are for the Ally Centre. So you've done a great job of sort of, talking about the work that you're doing, and we also know that the Ally Centre has an excellent track record of providing compassionate, community-based care in Cape Breton. I'm just wondering, first, can you talk about the population demographics of who you're seeing at the centre lately, first of all?
Ms. Gardiner.
Sure. Actively homeless populations, typically. We have really seen that population grow in Cape Breton. It's a very visible population. I call it the Ally Centre magic. They have a really good relationship with this population. So, oftentimes when we talk about programming, community-based programming, we develop the programs and then we find the participants. Well, at the Ally Centre, it happens the opposite way. We already have that relationship established, that trusting relationship. And so many folks are actively homeless. Many folks may be using substances. That's our folks. So very vulnerable populations. Many are struggling with mental health issues that have never been addressed.
MLA LeBlanc.
And are you seeing any changes in terms of age groups, more seniors, more young people, anything like that?
Ms. Gardiner.
It's an interesting question. It is a bit of a spectrum. We do have an aging population in Cape Breton, so there's many folks on the streets who wear palliative, and it's other than that, we know that substance use and living rough can take years off our life anyway. So we are seeing just because we're in Cape Breton, I believe too, and that's sort of the demographic that we have.
MLA LeBlanc.
Thanks. And with the managed alcohol program, are there barriers? You've mentioned the housing piece, but are there other barriers that you've come up against in terms of providing support through the MAP program, or MAP?
Ms. Gardiner.
Yes. A big piece is building those partnerships. I started this role a year ago, actually this week, and to develop the program, which that was the easy part. The big piece is developing the relationships within the community with other organizations, them understanding the program, trusting the program. That has been a big barrier. Also, because we don't have a harm reduction model supportive housing setting, it's sort of delivering new programming for our partners.
MLA LeBlanc.
Yeah, well, I guess this is maybe a two-parter for you and for the department, but I guess the big question is what do you need from the province of Nova Scotia in terms of ensuring the success of the centre, the programs? Is there enough funding for frontline workers, that kind of thing? Is there a big gap that you see, or any gaps?
Ms. Gardiner.
Yes, infrastructure. So right now we're building the RHI. You may have heard of that, a $5 million project happening in North End, Sydney. We're about January 2025. That should be ready, 24 units. harm reduction supported housing. In the meantime, we're just making do. So we have pulled together shelter. We have folks staying overnight at our shelter. I'm hearing that funding is running out soon, but the weather's nice.
MLA LeBlanc, did you?
Yeah, I have
you
another
wanted
part.
You're good?
No, I have another question.
Go ahead.
Yeah, so I live in Dartmouth North and represent Dartmouth North, and we have the Overlook in Dartmouth North, and I just got a chance to take a really awesome tour of the facility and, meet a bunch of the staff and meet some of the residents, and it feels really good there. And so is this RHI, is this a similar thing? And I guess the bigger question to the department is, are we looking at other models like the Overlook for other areas of the province?
Ms. Gardiner first, and then I'll go to the department. Ms. Gardiner. I think there we go.
Great. Yes, so when I first started, I visited the Overlook. It was so exciting. Definitely the model that we are following. They are doing some amazing things. Ideally, I would leave here today with a hotel so that we could do Overlook. Really, Overlook is, yes, that's exactly the model that we are looking at. And we work very closely. MAP runs out of Overlook. They have actually met with North End Communities Health Centers, managed alcohol program manager this morning, and they have really made some great progress with their MAP program at Overlook.
Deputy Minister Trott. Sorry. Deputy Minister Trott.
Oh,
Perfect.
There we go. Yeah, so we are absolutely looking at that model and working with the North End Health Clinic on the work that they're doing there and evaluating. I think that we're seeing what they've laid the foundation for in this area. Really, they've matured in this area here, so we need to take what they are doing and help support them, support other organizations like this in other parts of the province that have these significant hotspots needing these type of facilities. So yes, we are absolutely looking at other parts of the province.
MLA LeBlanc.
Dr. Hickcox.
Oh, okay. Dr. Hickcox. Hickcox.
I was mumbling, sorry. Yeah, I just wanted to say, I think you've heard even just one of the main challenges with really standing up new services is less about investment in necessarily just coming up with some money, but it's, a huge component is just finding healthcare providers and other folks in the helping professions, right, to do the work. And really of great import is the sort of ensuring that people who have the skills to not just use the buzzword trauma-informed care, but actually have the capacity to provide trauma-informed care, that really understand what the components of harm reduction care provision would look like, particularly in populations of folks who are really living in chaos. And so we know that the majority of healthcare providers who, like the largest cohort of healthcare providers qualified to do so is in Halifax. And so the province has invested through Nova Scotia Health and also in partnership with Doctors Nova Scotia a new program of harm reduction education for healthcare providers across the province using a model of mentorship. It's through an organization within Nova Scotia Health's mental health addictions program called the Atlantic Mentorship Network for Pain and Addictions. So we're really actually leveraging the expertise of some of the healthcare providers who actually work at the Overlook to really try to expand the kind of orientation of harm reduction to healthcare providers across the province. And that's an absolutely essential component here, is not just finding healthcare providers, but people who actually have the skills to do so. So that's an important investment, I think, as we go forward, right? Because it would be pretty easy to sort of stand up a bunch of buildings and then to have really inadequate capacity, right? So.
MLA Lachance. 11 minutes.
Okay, thanks. So I wanted to ask a bit about, I think in Nova Scotia, one of the things we're seeing is a shift, right? So I think for a long time we have been a little bit isolated from the toxic drug supply that has plagued the rest of the country, and that's no longer the case. And, you know, at the same time, across the country, of course, there are various different ideas about supporting addictions and substance use and supporting withdrawal management. So I wanted to ask you a question, I think probably Deputy Trott to start, but you can pass it amongst yourselves. Has there been any discussion about forced treatment plans, like we're hearing talked about in New Brunswick and in Alberta?
Deputy Minister Trott.
Yes, thanks. We're watching that quite closely, and we do not have any plans right now to embark down that path. But you know, we'll be watching what Alberta and New Brunswick are doing there.
MLA Lachance.
And I was also wondering, again, with this idea, you know, the difference between the beds, which I took Dr. Martell's comment about people lying down for treatment, but that's not actually what people do, right? People live their lives and seek treatment at the same time. And so the recovery centers. And so I'm wondering if at this point, if you have some outcome data that compares, like, do you have a sense of the right pathways for the right people at the right time in terms of beds versus recovery centers? And do you have a sense of recovery centers for a certain population to be more effective than inpatient treatment? I don't know who that.
Apologize with construction. I think you said Dr. Martell, but I wanted to make sure.
Sure. Whoever can answer the question.
Oh, is it Dr. Martell or is it someone? Dr. Martell.
I can have a go at that. I think what this speaks to is we talked earlier about being data-driven, and we have these discussions around our leadership table, and that part of every program that we build also involves evaluation frameworks that allow us to inform whether or not we're having the kind of impact that we want to have. So we are collecting data. We're in a situation now with recovery support centers being a new model that the one that opened, the first opened only in January of 2022. So that data collection process is, you know, taking place. Trying to draw conclusions based on that limited data set is difficult, but things do look promising. It's also trying to figure out, well, what are the best ways to measure success? Historically and in the medical literature, the way that success is measured is by engagement in care, and we prioritize that in these settings, keeping track of people who have been lost to follow-up or people who drop out. But I think there are other important ways to measure success. Personally, I believe in there's a certain way we do this data collection through what's called routine outcome measures, taking stock of, well, what are the social indicators of their health right now, what might they be at X interval through a process of engagement with one of these centers. So introducing those tools to help us measure will be critical to understanding our data. But data collection is key to having this really be effective and to show it.
Oh, Dr. Hickcox?
Yes, please.
I'm going to mess it up, sorry.
I accept your apology, Mr. Chair. No problem at all. Yeah, thanks for the question. I think it's an important one. We are I think it's really nice that our entire mental health addictions program is aspiring to bake into any new program development sort of ongoing continuous quality improvement and outcomes-based measurements. So more to come. The development of this model really, it's not so much about, it was based on, the available medical literature, multi-country, jurisdictional scan and so on. But what we really came to learn is there's no off-the-shelf model for addiction care, right, and for withdrawal management. What the evidence really shows us, though, is that the traditional notion of people going for a very short period of time into an inpatient setting and going through withdrawal so they no longer actually have tolerance or withdrawal symptoms and getting some initial perhaps some counseling or other kinds of sort of basic care, and then leaving essentially as a standalone intervention is not particularly effective. It's effective for a small cohort of people who are highly motivated and would likely actually do well on their own as it is. Substance use disorders are chronic diseases, and they require a chronic disease conceptualization, which is really kind of, I know it's sort of, the eyes can glaze over quite easily, but I think it's important to recognize that the way we've tried to conceptualize and structure this program is to assume that. So there are people who go now into our inpatient withdrawal management units. They meet the criteria for those. That's the care they need. Right afterwards, the day afterwards, they can go to the recovery support centers and actually get care, right? Now, that's not to say that that's all set up perfectly seamlessly across the province. We still have work to do, but that is the model, right? People can kind of go into a higher level of intensity or to a lower level of intensity as needed. We do have well over 5-6 years of data showing our initial model of ambulatory addiction care, which was started actually in Lunenburg, and Dr. Martell was two people who founded that initial program many years ago, clearly shows that the number of people seeking treatment increases, the number of people who actually stay engaged in treatment increases, the actual amount of potentially high-risk medications that are used to support withdrawal management actually decreases, and the amount of time that people need to go through that intense acute period of withdrawal management actually decreases as well with ambulatory care. The best estimates we have is that approximately 80% of people who need some kind of medically supervised withdrawal are going to do well with that initial phase in an ambulatory setting, in an outpatient setting, like you would find in the recovery support centers. And then approximately 10% probably need inpatient, and then about 10% probably could do withdrawal management either in a home-based setting or a non-medicalized kind of setting. So with that said, what's really key here is a model that allows people to get connected to ongoing care. That's the most important thing. The analogy I often use is if you have a young child who initially gets diagnosed with diabetes, type 1 diabetes, by actually presenting to the IWK emergency department in a state of unconsciousness. And it's very rapidly deemed that they need acute care to stabilize their blood sugar levels. They'll be admitted to the pediatric floor perhaps for 2 or 3 days. They have an entire interdisciplinary team, a lot of diagnostic imaging, and so on. That person gets stabilized. So imagine after that week or 3-4 days, they get all stabilized, everything's all good, they get their insulin doses, and then the team said, okay, good, you can go out now, try not to get high blood sugar again, right? So we would just laugh at that, right? They need to be connected to ongoing care. And that's really the way addiction care works, whether you have folks who are not contemplating stopping substance use and need more intensive harm reduction interventions, such as managed alcohol, for people who actually their goal is abstinence. There are people who will relapse and remit. There are people who, and probably about 50% of people, for example, with alcohol addiction, the first time they seek treatment, they go into remission for the rest of their life, right? Which is comparable to other chronic diseases, actually. But those folks are still doing chronic disease management. It might be actually managed by their family doctor, by actually less and less about the medical system. In the same way that someone with hypertension that's really well controlled is actually going to be treating their hypertension with exercise and diet, right? They aren't necessarily going to need medical intervention. So I think that's where what's important about withdrawal management is it's a component of addiction care. It's an important entry point. It's life-saving in that sense. But it's really the beginning of the story of care for people.
Thank you. MLA LaChance was just under 2 minutes.
Okay. I'll ask maybe a quick question. So in the government business plan for 2024-2025, on page 9, there's a statement, we will continue to invest in harm reduction initiatives like managed alcohol programs, sobering and drop-in centers, and overdose prevention sites in 2024-2025. Is there a plan to have additional OPS open in this coming year?
Deputy Minister Trott.
I think we are looking at the context of what's happening and considering if there needs to be additional sites. The other piece could be more products made available for self-testing as part of that. So there's a few areas that we're looking at around harm reduction.
MLA LaChance with 1 minute left.
So that was actually going to be one of my next questions, so maybe I'll just set that up and we can come back to it either in the next round of questioning or when we come back here. But around the idea of expanding the successful naloxone program to other supplies like testing strips and that sort of thing that are more available in the community.
Deputy Minister Trott, with 35 seconds.
Yeah, no, that's exactly what we're looking at. And even with the naloxone kits in their current form, so is there a role for the spray kits as opposed to always the needle, for example, in certain environments? So we're actively looking at all of those pieces, and even how do we, if we have a hotspot and an acute situation, how do we respond quickly to that community so that education is happening and folks are attached to the right supports and
Order. The time for the NDP have elapsed. It's next to PC, ready for 20 minutes. MLA Barkos.
Thank you, Chair. My first couple of questions are for the Office of Addictions and Mental Health. I'm just wondering, how do you address the unique needs of rural and remote communities in regards to withdrawals or symptoms, or services, I should say?
And that will be for Dr. Hickcox.
I can give it a go. So, in part, that's we're in a different era of entry into addiction care compared to a decade ago, where essentially at that time, if you were living in a rural or remote area, your options were usually to travel somewhere after waiting perhaps 2, 4, 6 weeks to then have a period of time on an inpatient unit outside your community. When we landing on 11 sites for the recovery support centers will increase the capacity of the entire system to provide care to more people, particularly those in rural and remote. We're also we've learned so many lessons, of course, from the pandemic regarding virtual care and the provision of virtual care for withdrawal as well. And we have significant precedent outside of the province, and as well as about a year of experience showing that healthcare providers can actually provide support for patients at a distance if there are, for example, a setting where you may have shelter staff or nursing staff available, but a physician or a nurse practitioner could be actually remotely connecting to the care team and providing withdrawal management services as well. So we're looking to do that more and more. We're hoping to potentially expand the addiction medicine consultation service as well to provide more support for community hospitals so that those hospitals actually have the capacity to provide more withdrawal management even in their own small rural emergency departments.
MLA LeBlanc. MLA Barkos. And I keep looking at them. I don't know. It's a day.
That's twice now today, Chair.
Yeah, I know.
So how does the Office of Addictions and Mental Health collaborate with other government departments to provide holistic health programs or support, I should say?
Deputy Minister Trott.
Hi, thank you. We work very collaboratively with a number of government departments on this topic and many others. We definitely are working very closely on how we approach the increased need for the vulnerable population we're dealing with around addictions and mental health, including DCS and Nova Scotia Health and others. But really trying to break down those silos and come together to co-develop ideas and approaches that we can deploy together. I think a great example might be the bridge, because that facility, although run by DCS, we're all participating in providing services and supports on site there, along with other departments. So it's a really important effort that's happening around breaking down those silos, and we're seeing it in this work, we're seeing it in the response to the mass casualty work, and so on. Lots of, in particular, this core group of social departments that we're really working closely together.
Just before I recognize you, I've remembered who you are. If everybody could make sure they speak into the mics and a little louder just because of the noise in the background. MLA Barkhouse.
Thank you. And my next question is for Direction 180, and I never preamble. I'm like to the point kind of lady, but I just got to say for the Ally Center and the Direction 180, I 100% understand what you guys do and offer, and I'm very happy to be here with you. I'm sure all of us, we've been touched by this. Not, for me as a family, I have the Helm in my constituency, which I adore. And about 6 months before the election, I had a woman come to me, and she's been now almost 3 years or a little over 2.5 years clean because we found the money within the community. She wasn't in my constituency, but we sent her out of the province, but still in Atlantic Canada for a 1-year program, and it changed her life. And so I heard, this is for Direction 180, I heard that Direction 180 has the first overdose prevention site in Atlantic Canada. Can you tell us more about the initiative? I'd like to hear about that.
Mrs. Martin.
Thank you, Chair. Yes, so Direction 180, we have been operating the first overdose prevention site in Atlantic Canada since 2019. So the service began operation through volunteers, people with lived and living experience, volunteering their time to operate this service. It is a non-medical model, so there are no physicians or nurses on site. Everyone is trained with basic life support, an AED, oxygen, as well as naloxone. And the reason that our initiative started as a non-medical model was because we know for a lot of our folks, there's a lot of hesitancy as well as lack of trust when it comes to health services. So we wanted to ensure our community's most vulnerable people who are using substances in unsafe ways felt comfortable accessing our services. So that's how we began. There was a little bit of funding through donations, community funding, crowdfunding. We are now happily supported through the Nova Scotia Health Authority Public Health. We are a funded program since January 2022, and they have graciously increased our funding this year as of January. So we have been able to, as Dr. Martell spoke about earlier, all of the data collection really shows that our service is working. Like I mentioned earlier, we have prevented 7 unnecessary opioid drug poisonings in our community just by being open, by people feeling comfortable coming to our space to use some substances under the supervision of trained staff.
MLA Barkhouse.
So you hit a lot of important things there, but that trust is very important. You need to have that. Could you just tell us maybe some of the other programming you have?
Mrs. Martin.
Thank you. Yes, so specific to, the Refix Overdose Prevention Site is a program of Direction 180. So it is one of our larger programs. Not only do we provide a safe space for people to use substances so that they're not using in public, they're not disposing of drug use equipment inappropriately, whether that be in a park or on a trail or within a sheltered alleyway where, a community member potentially could walk by and get poked by a needle unnecessarily. We're also offering drug testing strips on site. We offer naloxone training. So not only are people coming to our space to use safely, but they're leaving with the tools that are necessary to keep not only themselves, but their friends safe in our communities. As well, we have staff who are there solely to link people with health and social services when requested. So a big thing among our folks, a lot of our folks who access our service are precariously housed, so they need help securing whether it be a shelter bed, whether it be getting into the overlook for more wraparound supports and services, obtaining a room at the bridge. We have people on site who can sit with them and help support them through that process, because when you're in active addiction, it's extremely difficult to navigate the systems. It's extremely difficult for us as staff to sometimes navigate the systems, so being able to support people through that process really helps support connecting them with the additional health and social services that improve their overall health and well-being.
MLA Barkhouse.
Thank you for the answer. So I have a, with my last question, but before I want to thank you all for what you do, but thank you for this. Have you ever thought of maybe, or considered expanding throughout the province? And this could go to 180, but also the Ally Centre, because, yeah.
So Direction 180 and the Allied Centre, is that MLA Barkhouse?
Yeah.
Okay, Mrs. Martin.
Sure. Just a quick note. I mean, every community should have a safe space for people to use substances. People are using substances in our communities every single day, and being able to help connect them with other health and social services is how Nova Scotians will thrive. The province has expanded services into Cape Breton, so I'll allow the Ally Centre to speak to their overdose prevention site. Thank you.
Ms. Gardiner.
Yes, so we do have an overdose prevention site in Cape Breton at the Ally Centre. It's very busy. We were just chatting, we have about 200 registered participants in comparison to the Direction 180 or around 400. So, yes. And yeah, so we've been in operation since June. Last June, we were 1 year. And yeah, so so at our site, just to give you an idea, we have the overdose prevention site, we have a drop-in center, we have a clinic downstairs, and now a shelter. For now.
Thank you. MLA Barkhouse.
Well, I'm going to pass my the rest of the time down the road to MLA Palmer.
MLA Palmer with 8.5 minutes.
Thank you, Chair, and I too want to thank you all for being here. Some of on a more than the first time, and some for the first time. Welcome. Definitely, we're hearing lots of information today that's so important and vital for us as policymakers to hear and Nova Scotians to hear. You know, we've heard a lot about collaboration amongst departments, and I guess my first question would be to maybe Dr. Martell. You mentioned in your opening statements, you talked a lot about collaboration with community organizations, and that's why we're here together at the table. Can you, I guess, expand on how you collaborate with community partners and how you enhance the withdrawal support between the two of you? And maybe I could I'll ask Dr. Martell to give your perspective on that collaboration, and maybe I can ask Ms. Martin or Ms. Gardiner to give your perspective on that collaboration as well.
Dr. Martell.
I could speak to my own experience. I think it's important as well, though, that we hear from someone like Janah Fair, who very directly has had involvement with these collaborations and can speak to the experience and the value of collaborating and how it takes place on the ground. So maybe Janah, can I get you to speak?
I'd love when a bunch of gentlemen get up for that. So Janah Fair will be, oh, perfect, they've got your mic on. Janah Fair.
Excellent, thank you. And thank you for having me today. So partnership, as Dr. Martell mentioned, is opening marks are so important to our community, and I think it helps reduce stigma and it helps us do more and reach more people. So some examples that we have been working with community in Northern Zone, we noticed a need to spread the accessibility and information around harm reduction. So we've been having community pop-up events since our initial ones in the Spring Hill community, where we partner with partners in the health system, so primary health care, public health, and also partners in the community. So we've partnered with our local harm reduction agencies, Northern Healthy Connections, many grassroots community organizations who have an interest in supporting their loved ones and care, and our Take Home Naloxone program, pharmacists, and we are having events to kind of allow the community or people with lived and living experience access more information and support for harm reduction services. I think that's something that's how we solve problems, is to include our partners. So we're always looking for opportunities as we design our systems of care to build on those partnerships, and work together.
MLA Palmer, was your question to also 180 or out?
Maybe I could ask Ms. Martin or Ms. Gardiner if they'd like to maybe share from the community perspective the collaboration with the department.
Okay, so I'll start with Ms. Gardiner first this time.
We have some great partnerships with the offices. What we really struggle with in the community is confidentiality around other organizations, and that can be hard when you're trying to advocate for individuals and you're not allowed to use their names. That is one barrier that we really see in working collaboratively with other organizations. To give you an example, which I think I can do, would be if somebody wants to stay at our overnight emergency shelter, they must not be allowed to stay at the shelter up the street. We're not allowed to call and ask. The individual has to call and put it on speakerphone, and we have to listen. So, you know, it does create those barriers in care when confidentiality is just too big. So I just wanted to make note of that. But in terms of our partnerships with government, things through funding, things are moving along in Cape Breton, but it really is just that piece around how do we help folks. There's been a lot of work around coordinated access that they have really struggled with, and it's around that confidentiality piece.
Mrs. Martin?
Sure. Thank you, Chair. So in the community, we do a lot of collaboration with Nova Scotia Health Authority, the Office of Mental Health and Addiction, Department of Community Services, all of those key stakeholders. It's extremely important that we have these ongoing partnerships, collaboration, so that we're able to really share what's going on the ground. When we're working with people on a daily basis who are struggling, we can share that with policymakers. We can share that with the system so that they truly understand the needs of the clients that we're serving. We also collaborate on a regular basis with Nova Scotia Health Authority around the development of policies and guidelines that support people who use drugs. So we are invited to the table and we appreciate it, and it works really well when we come together and work together.
MLA Palmer with just under 3 minutes left.
So obviously this topic is vitally important in the addiction services. I think it's one of the priorities was of our government when we came to office to create a separate department for the Office of Addictions and Mental Health with a designated minister to put the focus on these issues. So I think that was an important step in how we're moving forward. Just a quick question. About the opioid use. I represent Kings West, and we have the Western Kings Memorial Health Center and an opioid recovery center on site there, and I've had the minister to a visit with some of the staff there and met with someone who's gone through the program. Can you just talk about how opioid use, from a societal perspective, has changed over time, and how the government has been responding with a center like the one that I discussed in Berwick?
Dr. Hickcox?
So do I have like an hour?
1 minute, 50 seconds.
We've been relatively spared from the worst ravages of the opioid poisoning crisis that has been sweeping across North America. And I think it's safe to say that with the bolstered by the enhanced surveillance that we've been afforded with our 2017 opioid overdose and response framework, we've really seen a marked change in the last. It's been a bit gradual since the pandemic started, but we're really relatively spared from sort of marked increases in mortality, and the majority of opioids that have been used by people who are using opioids in non-prescribed ways has been prescription opioids. That has changed in the last year to year and a half. It continues to change. We're seeing more fentanyl and its analogs coming in to Nova Scotia, highly potent, very dangerous, and more crystal meth coming in, and more non-prescribed, highly potent benzodiazepines, tranquilizers. So this contamination of the drug supply has led to an unprecedented increase in mortality in this last calendar year. Our response to it is to address this as an emerging crisis. We're bringing together multiple government departments. We're going to be listening closely and doing our best to build trust and establish relationship with people lived and living experiences with healthcare providers across the province, and really learning from other jurisdictions what we may put in place. We have an opportunity here, and it's an opportunity to try to do our best to mitigate the kind of harm we've seen across the country. It's going to be a really difficult time.
Order. PC time is elapsed, and the next round will be the Liberals, and it will be 7 minutes. MLA DiCostanzo.
Thank you, Chair. And I'm just going to take the 2 minutes from the 7 and leave the 5 for my colleagues. So this is just a bit of a burning question, but if we can go fast with the answer. What I'm looking for is, I'm sure you're aware of the Clause 110 that was in the FMA that was very concerning to our party and the NDP of having the minister having access to people's health information. All you guys talked about is trust, lack of trust of the patients, the confidentiality issue, the hesitancy to use services. Imagine if you tell them that your information is now in a department and so many people have access to your name of using this information. So my question is, how do you feel about that, and were you consulted, and this is to the two organizations, were you consulted about this clause?
MLA DiCostanzo, when you say two organizations.
Sorry, 180.
We have 4 here, so just making sure.
No.
So you mean 180 and allied?
Correct. Okay. I apologize.
So since I did that way, Mrs. Martin?
I was unaware of this.
Okay. Ms. Gardiner?
I was unaware as well. It probably would be something our board would be aware of.
MLA DiCostanzo, you have 30 seconds based on the 2 minutes you told your partner, so I'm just saying.
Maybe 1 minute, more. How do you feel about it? Would you hand that information to the minister as an organization?
I'm going to go backwards. Mrs. Gardiner. Or Ms. Gardiner, sorry.
That's a good question. I'm not sure. I'd need more time to think about that. What would be the benefits of sharing that information? What would be, the negative consequences of that? Yes.
Mrs. Martin.
Yes, I would need a better understanding of specifically what information it is you're talking about, because there is the Privacy Health Information Act. So are we sharing individuals' names, or are we sharing, how many folks are accessing our services for a specific reason? I think it's important that we share that information to inform our funders, are we being funded adequately, or do we need more resources and services? So the specific information I would need to understand more.
So, MLA DiCostanzo, you're at 4 minutes and 18 seconds left. MLA
So
DiCostanzo.
sorry, yes. I will speak to them after about it, and I'll pass it on.
MLA Tilley, 4:10.
Thank you, Mr. Chair. And given the emerging crisis that we are experiencing here in Nova Scotia, this is a question to Direction 180 and the Ally Centre. What do you feel are the missing gaps in our public system that you as organizations see on a daily basis?
I'm expecting you meant for...
Direction 180 and...
Okay,
yeah.
so Mrs. Martin, I'm trying to get this, so I'm flipping back and forth here.
Sure. So as I'm sure we can all see, the housing crisis that is currently happening across the province as well as the country, it's extremely difficult to support someone or even have a conversation about treatment when they are living outside. For many of our folks, they're just trying to survive. So when we talk about treatment, it's extremely difficult to even think about treatment or accessing health services when you don't know where you're sleeping that night.
Ms. Gardiner.
Thank you. Yes, I would agree. Definitely housing, appropriate housing models that are an environment where we can run the programming that folks need. I guess public housing is not the place. That's what we're seeing in Cape Breton, a real push on public housing. Doesn't work for folks who need harm reduction programming.
MLA Tilley.
Thank you, Mr. Chair, and thank you for those answers. I guess the next question I have is kind of for the whole panel. We are seeing, 73, I think, was the number of drug toxicity related deaths this year. Are we seeing a rise in younger clients, both at your system and through the addiction system itself? And what can we do as a province to help stem that if we are seeing that? Thank you.
Okay, so I think I'll start, because you want all groups? Okay, so I'm going to go right to left. Mrs. Gardiner? Ms.
That is interesting. I've often thought about doing some education in high schools, and did a little bit of research in our area around high schools, and if they are seeing needles disposed of, and they're not, from what I'm hearing. So I think that public education is starting to hit the next generation, so that's really good. I've only been at the Ally Centre a year, so I really can't speak to that. It really is a spectrum of individuals. We don't see a lot of younger folks. If we did, we would be very concerned. But typically, folks are 23 and up is in my experience.
Mrs. Martin.
Yes, we do see a younger generation coming through, and when I say younger, I mean between the ages of 18 to 30. And I suspect the reason for this is because Nova Scotia Health Authority, as well as the Office of Addiction and Mental Health, has done an extremely wonderful job investing in addiction and mental health services. So Nova Scotians can access service when they need it. So there's no delay in treatment access. And I anticipate that that's why we're seeing younger people access our services, because they can access the service when they need it, and they don't have to wait 5 to 10 years until they have other health concerns that land them in hospital and then their addiction is treated. So I see it as a positive thing that we're intersecting earlier with younger populations, because as we know, people use drugs and they will continue to use drugs, so they should be able to access treatment when needed.
Deputy Minister Trott.
Thank you. It's an example of the success that's come out of the 2017 opioid framework, because we have the data now. We're able to really watch the trends. Unfortunately, we actually had 128 deaths. We had 128 deaths last year, 74 of which were from opioid toxicity. So it was a little higher than what you had mentioned there. And there's some pieces that we're seeing, and in our last report, we're seeing some more...
Order. That's the Liberal time. MLA LaChance with 7 minutes.
Okay, I'm going to try and go through a speed round. So we ended our round of questioning talking about some of the prevention and harm reduction work being done. I listened to White Coat Black Art on the weekend, but there was a story about in Ontario there had been a funded naloxone workplace training program. And I'm wondering if we've considered being able to roll that out in workplaces in Nova Scotia, and I would add like community organizations and that sort of thing.
Deputy Minister Trott.
Yes. So these are the pieces that we're looking at, and I mean I can share that Dr. Sam and I did a training session with deputies a couple weeks ago, actually, and we think that there are a number of organizations out there, large organizations, who have staff that they know are facing addictions, and we want to make sure that, in best supporting that employee, that their environment is the safest as possible and that they can remain employed and all of those things. So yes, absolutely, we're looking at that.
MLA Lachance.
Yeah, and I think the other piece too, obviously, is for customers and for people, sort of passersby, like having, much like the AEDs that we have in public settings, right? Knowing where those are, having them marked, and having people being trained and being able to use them is really important. And I know when we were talking before, you mentioned, about nasal versus injection naloxone, and I also think that would be a good move. I know that lots of people are intimidated by giving a needle if you're not a medical professional. When I've had to break out my naloxone kit, it has been a moment, actually. So nasal spray would be great. And I'm glad to hear deputies have it. I usually make at least one member statement during our legislative sessions about naloxone's program. I have a kit in my desk in the legislature, so I think it's very important to have as top of mind, especially as the drug supply changes. Oh my goodness, I have like two questions. I can't decide which to start with, but I will start with what you're seeing in terms of different needs for withdrawal services for equity communities such as the 2S LGBTQI+ community, Mi'kmaq and Indigenous communities, and the African Nova Scotian communities, and how that's being addressed.
Deputy Minister Trott, and just over 4 minutes, MLA Lachance.
You want to take that? Yeah.
Or is who's taking it? Dr. Martell?
Dr. Martell.
I guess my one reflection is we were very deliberate when we set up our hospital consultation service to have a way to be recognized as being an ally to those communities. And you'll notice that I'm wearing a multicolored lanyard, and this is the reason. We chose this lanyard in those settings, to have people know that we stand up for people in these more vulnerable populations, and that it's a signal that we can help. This is safe space. So this was deliberate. I just wanted to highlight the lanyard. They cost a lot of money.
MLA Lachance, the Deputy Minister.
Yep.
Right?
Yeah.
Deputy Minister Trott.
Yeah, I also want to highlight the work that we're doing with Dutch Agamic. So the office provided $2 million for Dutch Agamic to work within Mi'kmaq community to develop their mental health and addiction strategy. So we're looking forward to that coming to fruition, so we can work together on how we implement. But we're really, we agree we need to learn from communities how they're best served and how we can really reach them and be there for them when they're ready.
MLA Lachance was just under 3 minutes. Oh, sorry.
Okay. I thought Dr. Hickcox wanted to hop in on that, but maybe on the next question. So, speaking of sort of ages and that sort of thing, one thing I've heard from parents and from young people is that sometimes, overdose deaths amongst young people are reported as something else. So that the number of young people actually dying from opioids or other substance issues could in fact be higher, is what family members would suggest. So it's recorded as a suicide or an ATV accident or whatever it is. And I'm wondering, with the new integrated youth services model being rolled out in Nova Scotia, how substance use services and withdrawal management will be integrated into those programs as well.
Deputy Minister Trott.
Yeah, because those the integrated youth service sites will be developed in partnership with local community, those areas that have that need, which we certainly know goes right across the province, will be integrated as part of the IYS sites. Absolutely, yeah, it's a key component for sure.
MLA LaChance with 1.5 minutes left.
Okay, then I'm going to go back to my first question. I think Daja Gamig is one example of a partnership. So that organization exists for the purposes of partnering around health in the province. With regards to the African Nova Scotian community or the 2S LGBTQI plus community, how are you finding and building competence and allies and community to do this work?
Deputy Minister Trott.
We actually have introduced a new position in the Office of Addictions and Mental Health for whose focus is on building relationships with communities to ensure that not only through funding agreements and things like that, but that we're bringing the right people together as we make plans and develop new services or reflect on our existing services and how we can make them better. We also have an advisory group as well that we are establishing that's going to play an important role as we continue to enhance services. But yeah, there's been a fair bit of conversation. The IWK has been leading some really amazing work with the African Nova Scotian community but to establish a clinic in community that meets the needs of youth and families. And it's a model that we think we're watching and learning from because it was built completely in partnership.
The time for the NDP have elapsed. MLA White.
Thank you, Chair. I have so many questions for so many of you. I don't
You have
know
7 minutes.
Yeah, I guess 7 minutes is not enough. But so I'll start with the Ally Center, Ms. Gardiner, because I have worked with your group before. We've had you in to train some naloxone training with some students in a youth group of ours, stuff like that. So I'm a huge supporter of you. I really am. But I have a question about, in your comments, your opening remarks, you mentioned the community hesitation for the pallet shelters. And I wanted to know what you're doing, what feedback you may have received already, and what you're doing to reach out and work with community to help settle that.
Ms. Gardiner.
Sure. So I can't really speak to that because my manager and my board would be dealing with that. And we've also partnered with New Dawn, and New Dawn has really taken the lead on that frontline role. Yeah, I'm not sure I can speak to that.
MLA White.
That's all right. I will be talking with Eric anyway. That's another great organization, New Dawn, absolutely. But so let me ask you this. As a counselor myself, a trained counselor, I understand the importance of building trust with the client and the situation. And I understand meeting people where they're currently at, and people are not motivated to change until the conditions in their life are such that they are motivated to change. So with that being said, I'm curious about, I want to support the clientele that you're working with, but I also want to, there's a very real concern in Sydney area, as you know, and I would be neglectful if I didn't speak about it today. So I do want to ask about it, because I also believe that the people in the community and the business district and everything else, with all the things that are going on downtown that they're seeing, I want to know if there's, being the trust and relationship that you have, and you talked about that already, I want to know if that is used, and if you're looking at if you have a client code of conduct, if you're not, are you developing one, and are they held to it? Because this is where a lot of the community resistance is coming from. So I really want to cut to the chase. Let's get to it. That's where we need to deal with, because we have two sides that we have to please here.
Ms. Gardiner.
100%. We do have a client code of conduct, and actually the sad thing is the only thing we can take from folks is us. We're all we have. They have. We're the end of the line. So often the code of conduct means that folks are banned from our centre, and that works. because they need us. There's a lot of issues going on. We know that with trauma, unfortunately, comes violence. With this type of work comes a lot of gray areas that we need to be sure that we're supporting folks. But the Ally Centre's been doing this for over 30 years, and they're really good at it. That's one thing that the community, unfortunately, doesn't see what happens inside. They only see what happens outside. And when folks are living on the streets, unfortunately, they're living their hardest moments for everybody to see. Really, it's that lack of housing, supportive housing piece that is causing us to see so much chaos in the streets. If we had supported housing that met people where they're at, they wouldn't be living their worst moments out in the streets.
MLA White.
Yes, absolutely. I understand that. And most people judge you by what they see in the current moment, whether that's a week, a month, or it doesn't matter. The current moment, that's how we judge our encounters, not realizing that there's something that brought that individual to that point, and trauma or whatever it may have been. I'm going to ask you about risk factors in a minute. But in the end, we do have to, I think you are in the best position because you have that trusting relationship, and they're coming to you at a point in time when they need support and they're looking for it. And I think that is the time to ask for acceptable behavior, because we can't neglect the fact of what it's doing to a community in Sydney, right? So that's where I'm at. But I'll leave you off the hook for a minute. So I would ask a question, perhaps to Dr. Hickcox, is about risk factors. You know, when I think of such a, I don't want to say in particular, so when I think of neurodivergent disorders and the need for stimulation, for stimulants or whatever it may be, I want to know about at what point in a recovery is that considered? Because if we treat the current condition at a point in time, that's all we're doing. We need to treat what was the deciding factors to get into that position in the first place, and sometimes it could simply be a neurodivergent disorder that wasn't diagnosed.
Dr. Hickcox with minute 30.
Increasingly, the health authority, I think, is putting their money where their mouth is, and with respect to investing in developing a high-quality concurrent disorders care program. What does that mean? Concurrent disorder means providing care with specialized expertise in mental health, non-addictive mental disorders, including psychiatric care, and alongside addiction care at the same time. We recognize that anyone who is using substances, whether or not it comes from something that happened in development, whether or not it comes from an undiagnosed or perhaps undertreated other psychiatric disorder, at the time of treatment and entry into treatment, there are needs that are getting met by using substances. And if all we do is take away the substances and don't address the unmet needs, whether they're physiologic, unaddressed chronic pain, whether they're psychiatric, whether they're emotional, based in unaddressed trauma, often alienation and disconnection from ourselves and from society, and a loss of meaning. If we don't really look at that entire person and work to get those needs addressed over time, then that person's at risk of just going back to substance use, of course, like any one of us would. So in general terms, that's absolutely essential.
Order.
I think
Sorry, that's the end of all of the time. I don't know if anybody has any closing notes or not, so I'm going to go backwards just to see. Does Ms. Gardiner have any closing comments? No. Mrs. Martell? No. Dr. Martell?
I'd like to just make a closing statement because I think it's important that we end on a high note. It's that there's a conception out there that people suffering from serious addictions have no hope, or that they can't get better. And I'd contest that. The data that we have suggests that these diseases are very treatable as any other chronic condition. And the treatment programs that we have in place speak to that. And we should really have that frame of mind when we talk about it, that these things aren't hopeless at all.
Thank you. And last but not least, Deputy Minister Trott.
Thanks, all. Just a comment. I've been spending a fair bit of time in community this last while with community organizations and with our units and talking to folks. And what I would say is, I mean, it's so amazing to see the people who work in this space and, you know, really supporting people who are having such a terrible time in their lives. But the positive passion that these workers have and dedication to these people and providing that hope that they can get better is just exceptional. It is such difficult work, but we have the services and we don't want people to be left behind. And we're really excited that we had this opportunity today because it's not an area that we get to talk about a lot. So really appreciate the opportunity today. Thank you.
I'd like to thank you all for coming. That concludes your portion of it. We still have some committee business left. So, however, I will just give a 3-minute recess to let them go out. But in 3 minutes, we will be starting. We're adjourned for 3 minutes. Order. So we've got a lot of committee business. One thing I will start off with, MLA LaChance, you read from a paper. Was that part of a briefing note or separate? Because if it was separate...
But this is
Probably it's been tabled a few times.
and it's the government business plan.
Yep.
And I borrowed this version from the library, so I cannot table this.
Was it in the research briefing? Was it in the research briefing, the notes onto it? Because if not, the clerk has informed me that we will have to table that page. So
we'll get
just the page or the whole thing?
Make a copy of it. We'll figure that out.
Thank you, and you'll take care of it, and I trust it'll be done. Thank you, MLA.
I'm using a prop. Sorry, folks.
I don't know.
Don't worry. She doesn't trust you. I do. It's all good. Okay. Correspondence. We received correspondence from the Paramedics Union President, Kevin McMillan, in response to a request for information made at March 19th. It's been sent among members. Any questions regarding it? Take that as a note. Okay. Motion on the table. At the March 19th meeting, members discussed correspondence received from Nova Scotia Government General Employees Union regarding witness list for that day. A motion was made. I will have the clerk read the motion.
All right.
So,
yeah.
I would move that an explanation of the agenda setting process and the witness selection practice of the committee be included, as well as a link to the January 9th Hansard report and the April 11th, 2023 Hansard report, highlighting the motion related to the topics that affected them, and that the chair write a letter with those elements involved.
So the meeting time ended before a motion could be put to vote, and that's why it's on the agenda today. Is there any discussion on this? This motion was, well, technically after motion is made, it's the committees. However, MLA Regan had made the motion, and she did notify that she wanted it dealt with today, even though she's not here. So at the meeting, she had made a remark of that. So that's why I asked, is there any discussion, or are we just going to vote onto it? So any discussion? MLA LeBlanc.
Well, I'll just say it's a good idea. I mean, I think that, committees have been receiving lots of correspondence from different organizations who would like to have our representation at committee or will be witnesses at committee. And so I think it's very fair to write a letter sort of outlining the process and thanking them for their interest, in fact, in the committee. And that way, there is some official response back. Which is important, I think, so people know that they've been heard and their issue's been discussed, and that way we can move forward, with people or organizations knowing the way the committee structure works or the witness setting works.
Thank you, MLA LeBlanc. Any other discussion? MLA White.
Thank you, Chair. This letter should have gone out long ago, but the problem I have with this is the same problem I had with it in March. The meeting took place, I think it was January, wasn't the meeting, I believe, and the NSGU sat here right in front of us while we discussed the idea of a letter. So I really don't know what we're doing now. We're sending a letter out now in April for me and took part in January, and people who sat here and heard us discuss in clarity the idea of it was a liberal topic, and we accepted all the witnesses that were posted. And I think we explained it. I just don't know what we're doing right now. I feel we're going back, just digging up stones. I don't know. That's how I feel.
MLA LeBlanc.
Well, just to clarify, I think there was 2 letters from the NSGEU. I think this letter that we're talking about actually was after that meeting where the NSGEU came and sat. But I just think it should be a matter of course that if there are letters sent to the committee in like this type of correspondence, then we should have a mechanism for replying. We would all reply if they came to our constituency offices. Why wouldn't we reply as a committee as well?
Any other discussion? Or are you ready for the vote? MLA White.
Is the motion to send a letter to NSGEU only, or is the motion to send a letter to everybody that applies?
The motion as read by the clerk is to be sent to the NSGU, because that's who sent the letter to them. If I'm looking at the clerk for the clerk to nod, we would reply to NSGU. Not everybody. Yes, clerk? Recognize the clerk.
I can't speak to the motion.
If the motion passed, who would you write the letter to? If you're saying you can't speak to that either? The clerk.
I would write it to whomever the committee directed me to.
Perfect, thank you. So the letter would be written to NSGU, who sent us the letter explaining the process. I'm going to allow MLA DiCostanzo to speak first, and then I'll get MLA Barkos. MLA DiCostanzo.
Sorry, that's exactly what I was going to say. We reply to the person who wrote to us, or to the organization who wrote to us, and we agree with the with our colleagues, and a letter will be we should be replying, and we'll be happy to reply to them.
MLA Barkos.
So although, and you'll have to excuse me, I missed the last meeting, it was talked about while they were here. It was explained the agenda, but with that being said, I'm not against sending a letter stating the process. I'd like to hear the motion one more time, but I'm not against sending a letter stating the process and whatnot.
All right, I recognize the clerk.
All right. I would move that an explanation of the agenda-setting process and the witness selection practice of the committee be included, as well as a link to the January 9th Hansard Report and the April 11th, 2023 Hansard Report, highlighting the motion related to the topics that affected them, and that the chair write a letter with those elements involved.
Thank you, Chair. All ready for the vote? MLA White.
I don't want to talk out your motion. I want to vote on it. But I just want to say that I think this should be a practice for everybody that sends a letter in. I just don't understand why we're doing this for NSGU only. I want to let you have your vote. Thank you.
Okay, ready for the vote? Okay, all in favor, aye. Aye. Opposed, nay. Motion passed unanimously. Okay, one thing. So right now, June 11th is looking at a meeting which will be agenda setting. I'm just letting all the groups know now so that the caucuses can start getting their lists in. It is subject to change based on witness, but right now the clerk's letting me know. And at a previous meeting we discussed is the more advance notice for everybody, the better. So just that. Is there any other business? Seeing none, the next meeting is Tuesday, May 14th, 2024, from the hours of 1 p.m. to 3 p.m. Witnesses, Nova Scotia Health, Department of Health and Wellness, Nova Scotia Health Coalition, NSGEU, Doctors Nova Scotia, Pharmacy Association of Nova Scotia. The topic is private-public partnerships in healthcare. Meeting is adjourned.